Welcome back to 10-Minute Radiology Case Reviews with Dr. Benjamin W. Strong.
Welcome to the VRAD Trauma CT lecture on subdural hemorrhage. This is your host, Dr. Benjamin Strong. We'll be reviewing 5 cases of subdural hemorrhage, starting with static CT images, on which the findings will be designated by colored arrows and listed with color-coded text. That will be followed by a review of cine images with similar annotations. Our first case is of an isodense subdural hemorrhage. This is an extremely subtle finding. There is an isodense crescent overlying the right frontal lobe. Look carefully and compare it to the opposite side, and you can see there is a band of non-anatomic density separating the cortex from the inner table of the skull. This is a relatively straight CT scan, and so this slight leftward shift of midline structures also should help call your attention to the presence of a space-occupying lesion. On cine images, you can appreciate that that crescent of isodensity overlies the entirety of the right frontal cortex. So that is an isodense subdural hemorrhage, the bane of the existence of all emergency radiologists. Our next case is a non-accidental trauma resulting in multifocal subdural hemorrhage. Of course, this is an unfortunate association, that of non-accidental trauma and subdural hemorrhage, and this particular infant victim has subdural hemorrhages in the classic locations. Here, asymmetrically, along the left side of the tentorium. Here, overlying the Sylvian fissure. Note also the increased density in the fluid overlying both frontal lobes, suggesting that there has been a previous extraaxial hemorrhage. Here is a small focus of parafalcine hemorrhage, also a typical location for subdural hemorrhage. Note also that throughout this brain there have been large swaths of geographic cortical hypodensity. That is related to a simultaneous strangling injury. Lastly, we see more parafalcine and convexity density, consistent again with subdural hemorrhage. Here's the asymmetric tentorial density, the Sylvian fissure density, and increased density overlying the frontal lobes, the parafalcine density, and last, the densities at the vertex. So that is a case of multifocal subdural hemorrhage resulting from non-accidental trauma with coincident strangling injury and multifocal ischemic damage to both cerebral hemispheres. Our next case is one of subdural hemorrhage with subfalcine herniation. This patient has a large right extraaxial density with small hypodense elements and a laminated appearance, suggesting it is an acute on subacute or possibly stuttering hemorrhage. This patient also has multiple locations of subarachnoid hemorrhage, interpeduncular, paramesencephalic cistern, and dependent intraventricular in a ventricle that is markedly dilated. On the next cut, you see this unusual hypodensity, which represents the right frontal cortex having herniated under the falx. On the next cut, you can appreciate even better that that is the case. And on the highest, you can see that this begins to conform to a vascular territory. That's easily appreciated on the cine, where you can see that this conforms to the distribution of the anterior cerebral artery. This is an established complication of subfalcine herniation, which is compression of the anterior cerebral artery with resultant cortical infarction. So that is a case of subdural hemorrhage with subfalcine herniation and infarct. Our next case is of subdural hemorrhage with uncal herniation. This is a large extraaxial fluid collection which is predominantly hypodense. There is a small focus of hyperdensity consistent with an acute on chronic subdural hemorrhage. There is significant mass effect and medial displacement and herniation of the uncus, which you see the tip of here. Both inferior horns are dilated, but for different reasons. The right inferior horn is dilated but contiguous with the remainder of the right lateral ventricle. That is related to the rightward shift of midline structures. The left inferior horn is dilated only at its tip and is pinched anatomically and is not contiguous with the remainder of the ventricle. That is known as a trapped horn and is related to the herniation of the uncus. Lastly, the brainstem demonstrates a marked central hyperdensity but is otherwise hypodense, deformed, and displaced. On cine views, you can appreciate the uncal herniation and trapped horn, and the centrally hyperdense brainstem. So that is a patient with acute on chronic subdural hemorrhage causing uncal herniation and brainstem ischemia with hemorrhagic infarct, a phenomenon known as Duray's hemorrhage. Our last case is of subdural hemorrhage with extensive cerebral edema. This patient actually has intracranial hemorrhage in all the major spaces. There is an epidural hematoma in the lateral aspect of the middle cranial fossa. There is density in the fissures consistent with subarachnoid hemorrhage. And there is our now well-established finding of ventricular inferior horn dilation. But note also the extensive cerebral swelling. The brainstem is hypodense. We have lost gray-white differentiation throughout the visualized frontal and temporal lobes, and there is a complete absence of the basal cisterns. Here to complete this patient's intracranial hemorrhage trifecta is a subdural hemorrhage, and consistent with the theme of hemorrhage everywhere, there is also a scalp hematoma. On the cine images, you can appreciate the hypodensity of the brainstem and the absence of the basal cisterns, all denoting severe cerebral edema and extensive brain injury. So that is a case of mixed intracranial hemorrhage with extensive cerebral edema. And that concludes our lecture on subdural hemorrhage. This is what you saw. Thanks for watching the VRAD Trauma CT series. This is Dr. Benjamin Strong, the host of 10-Minute Radiology Reviews. In the course of my career, I have worked as an internist, an emergency room physician, and an MR fellowship-trained radiologist. I'm currently the Chief Medical Officer of Virtual Radiologic, or VRAD, the nation's largest and leading teleradiology practice. With over 500 emergency teleradiologists and serving over 2,000 client facilities worldwide, we have access to an extraordinary amount of educational content which you see in these presentations. If you like what you've seen, please feel free to share, comment, subscribe, or for that matter, join the nation's leading teleradiology practice.